I would like to begin today by asking you all to set your intentions for this session. I want you to think to yourself, what do I want or hope to get out of this? My goal is that each of you will be able to pick out even just one small point and be able to immediately apply that to your daily scanning. In hopes of helping you achieve that goal, I would like to share two of the following quotes. The first by an American author and motivational speaker, Zig Ziglar. There is no elevator to success. You have to take the stairs. And the second quote is from one of my all-time favorite people, Albert Einstein, and he says, "If you can't explain it simply, you don't understand it well enough." Now that we have set our intentions for the session, these are the concepts I will be sharing with you today. Qscan, tissue-specific optimization, or TSO, dual screen, quad screen, and twin view, target practice, color frequency, filter, threshold, dynamic range, ergonomics, and finally, Knobology. Some of these you will recognize, some you won't. Again, my goal at the end of this session is to make each of you excited enough about some of the concepts and inspire you to actively go out and apply them to your everyday scanning. So the first two concepts are Qscan and TSO, or tissue-specific optimization. Everyone who can operate an ultrasound machine at this conference should be extremely well familiar with the Qscan. This includes both sonographers and physicians. You may not use it 100% of the time, but you should be incorporating this into at least one portion of every single scan that you do. Qscan not only optimizes your 2D image quality, but it also autocorrects for baseline and scale when using pulse wave Doppler. Imagine not having to correct for scale and baseline ever again. Okay, maybe not ever again, but it can for sure eliminate the need to continually adjust by a significant amount, saving you time and frustration if you are unfamiliar with your machine. It's like legal cheating. Not only that, it is highly encouraged. So next, let's view a short clip of a live demonstration showing what this looks like from a scanning standpoint.
Okay, so once you've selected your preset and you're ready to begin your exam, it's typically important to activate the Qscan to have a good baseline throughout your entire image. So Qscan analyzes the entire field of view and adjusts the overall gain to even out your image and suppress noise in any cystic structures, so fluid or any cysts that you might come across in your scan. So I'm going to begin the scan, put the probe down here, and right off the bat my image looks like this. It's too bright in the near field, too dark in the far field, reverb in the fluid. So I can manually adjust these features with the gain and the TGC. And it's important to know how to do those things, but to save time, we can activate the Qscan, which will even out the entire picture from top to bottom and help us get a good starting point for the exam. So here's my initial picture with just starting the preset, and I'm going to press Qscan. It's going to adjust the gains top to bottom, nice even picture, and then from here I can use the gains in TGC to just brighten it up just a touch, and if I needed to, just decrease any of the reverb in the fluid with the TGC. Another function that's similar to the Qscan but might not be as familiar is TSO, which stands for tissue-specific optimization. So going back to physics, the speed of sound is different as it goes through different structures, slower through fatty tissue, faster through soft tissue such as the brain and muscles. And without making adjustments for speed, your image can appear to look distorted or a little less focused. The changes are subtle, but allow you to get a more detailed image. So we'll start with the TSO, going through more of a muscle tissue, so a faster speed of sound. So we're scanning here. We'll go to the brain here. Okay. So this is speed of sound optimized for muscle. If I decrease the TSO, you'll see the image just come into view a little bit clearer. And just to show that a bit clearer, I'll do it in a split screen because it is subtle. So here we have the TSO on a negative number. And then I'm going to, on this side, turn it back up to where we started. And you can see that the heart's much more crisp. And the diaphragm is a bit easier to see.
All right, so now that we've seen the live demonstration, here are some static images to compare. Let's begin on the left where we have no Qscan. You can see that it is brighter in the near field, darker in the far field. The image quality is more blendy or smooth. There's no real information that we can see below the 7 centimeter marker. It's very dark below that point. On the heart, you cannot differentiate the atria from the ventricles, and it's hard to identify any other fetal structures. Now let's move to the image on the right with Qscan engaged. We now have evenly distributed gains from near field to far field. The image went from blendy to more crisp. We can now appreciate information below the 7 centimeter marker. When looking at the heart, we can now easily identify both the atria and the ventricles. We can now even identify additional structures, such as segments of the umbilical cord. Activating the Qscan should be an essential part of your daily scanning and will save you both time and frustration, and it will also allow you to spend more time on more advanced image optimization tools, as the ones I'm going to show you later in this presentation. It is crucial to allow Qscan to become a part of your everyday scanning practice. So, where do we find this button on our machines? The Qscan will always be on your panel somewhere, most typically near the trackball or at least in very close proximity. This applies for most, if not all, ultrasound machines, both old and new. Your job today is to go home, find it, and use it. So next, let's compare two images using both positive and negative TSO. In both of these images, let's focus and bring our attention to the umbilical vein, the stomach, the placenta surface, and shadowing. The image on the right with a negative TSO shows a crisper picture. You can clearly demonstrate the borders of the umbilical vein and of the stomach, clear of any reverberation. I can now see the borders of the placenta, and I'm also getting a stronger shadow signal from the spine and now even from the ribs. The image on the left is still a pretty good picture, but the image on the right is better. So if you're having a hard time tweaking and making that image just a smidge better, try bringing down your TSO into a negative number and let the machine do the hard work for you. The TSO happens to be on the touchscreen for this ultrasound machine. As a rule of thumb, you will find the knobs or buttons that are most frequently used will typically be surrounding the trackball or on the console. The knobs and functions that are most advanced or more advanced may be on the touchscreen or on the second page of a touchscreen. Some functions you will not see unless you have hit or activated the button you require it for, like color or pulse wave. The buttons related to those functions will show up once you activate those specific things. For example, you need to activate your color before you will see the button for color frequency appear. The next concepts for 2D optimization are dual or split screen, quad view, and I just want to touch a little bit on what I like to call target practice. So let's start with dual or split screen. Most of you here are already using this function, which is great. We use it mostly commonly for limbs or extremities. This is good for showing a direct comparison of right and left. This also allows both you and the reading physician to easily identify or rule out any issues in the pregnancy. For example, the right and left hand or foot. Dual screen allows you to keep the same depth, zoom, and focus for this exact purpose. It is a time saver, and you do not need to optimize twice. It also allows you to start exactly where you left off from. For example, when I am scanning limbs or hands or feet, I always use the dual or split screen. I image one hand, hit the dual screen without moving, and I am able to start on the hand I just saw to ensure I am not scanning the same hand twice. Single screen does not allow for this. Another strong benefit of dual screen is for direct visual comparison. For example, when imaging the femur, when I have engaged dual screen, I can clearly see that both femurs are approximately the same length, have the same ossification level, and no bending, bowing, or fractures. As sonographers, we should be scanning in a sequential or chronological order as best we can and as often as we can. If you are scanning the left foot, scan the right foot immediately after. Right hand, left hand comes next. Same for femurs, humeri, choroid, ventricles, anything that has a matching side. This helps us to avoid missing things and keeps our scans organized for both ourselves and for the reading physician. On the right, I have demonstrated the up-down feature in dual screen. It's a simple touch of a button to go between right and left and up-down on this function. Embarrassingly enough, I was just shown the up-down function of dual screen this year. I promise you, my mind was blown. I have also now incorporated the up-down feature of dual screen in many of my general ultrasound exams, including for small parts and MSK. Here is a look at those buttons on the ultrasound machine. The dual split screen is on the console and near the 2D gain, almost begging you to use it. Once you are in dual screen, I look up to the touchscreen and I see dual layout. Then it's just a simple push of the touchscreen to go back and forth between left and right and up and down. Next, let's talk about quad view. Quad view works in the exact same fashion as dual screen, but allows for up to 4 active screens. Both dual and quad view allow you to start exactly where you left off by keeping the same parameters like depth, zoom, focus, dynamic range, etc. I like to use the quad view for every amniotic fluid index or AFI that I obtain. Using quad view allows me to ask myself, does the overall image match my measurements, allowing for less user error? Quad view also allows for easier recognition of abnormal. Without the overall view, you may not be able to fully appreciate how little fluid there is. This also prevents you from an overmeasurement, a common mistake that leads to false information of polyhydramnios. This also provides a really great overall view for the reading physician. If we as a group can standardize using quad view for obtaining AFIs, meaning every sonographer and every physician here today, I believe we will see a significant decrease in the errors made and reported related to amniotic fluid. The next concept is twin view. Twin view is a great function that provides a simultaneous 2D and color image. What a gift! Twin view can be used with normal color Doppler, power Doppler, and ADF, or advanced dynamic flow. Twin view can be especially helpful when you are scanning a difficult patient or have a difficult viz. The fetal brain, fetal heart, 2 umbilical arteries, and kidneys are some of the structures this is uniquely helpful for. This allows you to stop putting the color on, then taking it off, then putting it back on again because you feel like you have fallen off the structure or unsure of proper placement. Twin view is super helpful in both obstetrical and general scanning practices. In the 2 examples above, both the heart and kidneys are suboptimal in appearance with respect to 2D. But with twin view engaged, I can clearly see very good perfusion filling in the chambers of the heart and the renal arteries extending well into the cortex. Twin view here is conveniently located once again on the central console, just next to the 2D gains and the clip store. As you can see by now, taking the time to familiarize yourself with the console can pay off for you time and time again. I highly recommend spending some one-on-one time with your ultrasound unit if you want to become a seasoned sonographer. Next, I want to talk to you a little bit about target practice and why we continually make things more difficult for ourselves by shooting for a target that is so far away rather than bringing it close to us. What I want to stress to all of you is don't chase the target. Bring the target to you. I see this time and time again when I visit sites or go in to help with a scan. Many sonographers will struggle for several minutes trying to obtain a waveform or a sample of a structure or even clearing up a 2D structure. The biggest reason for this is due to image optimization, or rather a lack of. Often the structure or target is so far away or so small or displays insufficient color fill, etc., making it almost impossible to obtain a clear image or accurate sample. Let's compare these 2 images. The picture on the left probably looks good to most of you. The head is taking up 2/3 of the screen, the focus is in a good position, you can clearly see the circle of Willis, and there is decent color fill. But my actual target here is not the head. My target is approximately 2 centimeters of the middle cerebral artery. So make sure that you're optimizing your target rather than the whole image. Be specific. By decreasing my depth and zooming up my image on the right, I will now have a much easier time obtaining my sample and moving on with my scan. It is important to note that sometimes a baby will only give you one opportunity to obtain that critical sample that can change the management of the pregnancy. So when the opportunity arises, we all need to make sure that we are ready. I'm really excited to talk to you about this next concept, which is color optimization, including scale, gains, and color frequency. I'm just going to say that the order of operations matters for scale and gains. You should always engage or make adjustments to scale first, then color gains. It's kind of like putting your shoes on first and then your socks. It's not made to work that way, and you'll just be repeating the steps. So what is color frequency? I just want to point out and make it abundantly clear to everyone here that this is not the same as color gains. Again, color gains and color frequency are two separate functions. So to start off with, color frequency is not a new concept. It has been around just as long as 2D frequency. We just need to know where to look. What structures is it used for? We use them for low flow, low velocity, or bad angled structures. It acts in the same way as 2D frequency, which we all know how to use. So for low or harder penetration cases, we want to lower the frequency. Examples of this would be increased maternal body habitus, deeper structures such as a head that is low in the pelvis or a heart that is down, multiples with twins and triplets with one being hard to get to, or difficult penetration. Structural fetal examples of this would be for the renal arteries in cases of looking for renal atresia, MCA Doppler where there's a bad angle or it's deep in the pelvis or behind another baby, two umbilical arteries where there's a bad angle to your transducer, maternal uterine arteries which can be difficult to find, the umbilical cord with advanced gestational age or baby laying on the cord. We basically use it any time you're structuring to get flow in a vessel. You just need to decrease your color frequency. If you guys can change only one thing today, let it be color frequency. Try it. Trust me. You will thank me. You are welcome. So let's dive right into some visual examples. Both images of the umbilical arteries show the same depth, the same zoom, focus, and dynamic range. Also, the Qscan has been activated. The image on the left displays a high color frequency set at 4.5, which you can see on the right side of the image, while the image on the right shows a low color frequency. We have lowered it in this example to 2.5. What do you notice that's different? Here are some video examples of those same two umbilical arteries showing the changes of both a higher and lower color frequency. So let's start with the video on the left showing a high color frequency. As you can see, there is very little color fill happening with the color frequency set at 5.2. That is mostly due to the poor angle of the vessels to your transducer. They are almost completely perpendicular, making it hard to obtain any color fill. Now let's look at the video on the right showing a lower color frequency. Again, nothing has changed on my 2D image. Same depth, zoom, focus, and frame rate. I have only lowered the color frequency in this example. As you can all see, there is a dramatic difference from making only one change. High frequency, no color fill. Drop the frequency, more color fill. One common error we see in obstetrics is being referred for a single umbilical artery. As we all know, there is an increased risk for cardiac anomalies in light of a single umbilical artery, and the patient must be counseled on this and sent for a fetal echo. As technologists, you may not realize the implications as a sonographer, but this can often and will often induce a significant amount of stress on the mother and her partner. Now they have been told they have a high-risk pregnancy. They often need to travel to an MFM site for a scan with a specialist. They'll now meet with a cardiologist to go over more results. The list goes on and on. This is a patient that did not need to undergo the stresses of that finding, quote unquote, when in all actuality, we have not done our job. Color frequency is a majorly underutilized tool that we need to make the norm. Let's look at another example. Now let's take a look at the renal arteries and compare these two images. Again, we have only changed or lowered the color frequency. All other parameters remain unchanged. The image on the left shows color frequency at a scale of 5.2. The image on the right, the color frequency was dropped and lowered to 3.5. You can easily observe more color fill on the image on the right with a lower color frequency. This is helpful when assessing for renal atresia, which can be confirmed by the lack of a renal artery, among other things. Our final example is of the middle cerebral artery for color frequency. The image on the left is set at 5.2, while the image on the right we have lowered the color frequency or dropped to 3.5. Again, you can clearly see a significant change in color fill. Using the color frequency in the same fashion and ease of use as 2D frequency will be a game changer in your daily practice. Again, if you all take nothing out of this presentation other than one concept, please let it be this. Color frequency is your new best friend and will make you look like a pro time and time and time again. Referring to my earlier comments, you may not see the color frequency until you activate the color Doppler. After you have turned on color Doppler, then look for the CF or color frequency. Contrary to popular belief, these machines are designed with use of ease in mind. So think initialize, then optimize. Help your machine help you. Moving right along to pulsed wave optimization, including Qscan, filter, and threshold. Again, Qscan can be applied to both 2D and pulsed wave. As soon as you hit update to acquire your pulsed wave sample, the very next button you should hit is Qscan. This will autocorrect your baseline and scale for you. Sometimes it will seem like it's not working, but just give it a second. The machine is thinking, and I promise you it will optimize your pulsed wave for you. So what is filter and when do I use it? Very simply put, filter is a tool we use to take out noise or any unwanted information in a pulsed waveform. I want you all to think of your Brita water filter that you have at home. We use a filter to remove all of the waste, toxins, or unwanted material from our water. We use the filter in ultrasound in a very similar fashion for pulsed wave. So to demonstrate filter, we have taken a sample of a PR interval between the SVC and aorta. As we now know, the first thing that we should always do is to hit the Qscan when optimizing your pulsed wave. Again, auto-optimizing and adjusting your scale and baseline and giving you a really great starting point. So the image on the left has no changes to filter, while the image on the right has been optimized. As before, no changes have been made other than increasing our filter. So why do we use this? The image on the left does not allow us to properly see exactly where we need to take our measurement, and in this case, the measurement is time. You can see the aortic flow going above the baseline, but what isn't clear is where it starts or stops, or where the atrial contraction is. Can you pick out the waveform on the left? I'm a fetal echo tech, and I cannot. So, just like we would with the Brita water filter to take out the unwanted material, we will increase or add more filter in order to remove the unwanted noise of the waveform. Now on the right, I can clearly see where the aortic waveform starts and ends, as well as magically see the kickback of the atrial contraction. We use these very important time measurements to produce graphs that the physicians can plot to see how they will manage the patient. These are often in milliseconds, which tells you how crucial it is to obtain an accurate and precise measurement always in order to obtain the best pathway of treatment for the pregnancy. So, structures you can apply filter to when using pulse wave Doppler are PR intervals in the fetal heart, with umbilical cord Doppler, when obtaining middle cerebral artery Doppler, maternal uterine arteries. It's essentially good for all pulse waveforms. It's like fine-tuning after your Qscan and when you want to target very specific information from your waveform. Next time you're struggling to pick up a signal and want to get rid of any unwanted noise, simply increase your filter and allowing you to pick up the information that is important. On this ultrasound unit, the pulse wave filter is on the touch screen. Notice how close it is in proximity to the pulse wave button. Remember, initialize first, then optimize. Just as a recap, increasing filter will remove waste or unwanted noise from your waveform. Expanding on pulse wave Doppler optimization, let's talk about threshold. I want you all to have a quick glance at these two images. Look at the image on the left, look at the image on the right. Let's see what differences, if any, you can identify before I show you the next slide. I'm going to give you guys 10 seconds to do so. So putting those thoughts on hold for a moment, let's chat about what threshold is and when do we use it. Threshold is a function that is used to reject the small echoes or noise contributed from backscatter. Backscatter can blur the tissue interface and reduce the image contrast. Without getting too in-depth, I want to say that poor image contrast equals a blurry waveform. Threshold comes in handy when we want to include or disclude small but important amounts of information from our pulse wave. Let's take a look. Now going back to our example, the image on the left has a lower threshold. Let's look at the tracing. You can see from the arrow, the tracing did not include the information at the top of the waveform. It basically cut out that information and provided you with a pulsatility index value to only include what's inside of the trace. But what if you want that information? Isn't it important? The answer is yes, it is very important. So how do we tell the machine we want all of the information in the pulse wave to be included? We simply increase our threshold. This means that we make the tracing higher and include the information that we want. Increasing the threshold means to move the sample higher from the baseline. The opposite is true when we lower the threshold. We are simply moving the tracing closer or further away from the baseline, depending on what information we want to include or disclude. In the example on the right, we have now increased the threshold. I now have all of the information that I wanted to include. It may seem like a very small change, but notice the values in the pulsatility index in both. The PI on the left is 1.74, while the PI on the right is 1.53. This may change the management of a pregnancy. Luckily, it is not our job to handle the management as sonographers, but it is our job to obtain the most accurate information possible to allow the physicians to make the best judgment calls that they can. Let's help them do a really great job of this by using and incorporating threshold. Once again, notice the very close proximity of the threshold button with respect to the pulsed wave button. Your ultrasound units are built with user-friendliness in mind. Familiarizing yourself with your ultrasound units is something that will pay off tenfold for you, thereby simplifying your workload and allowing you for more downtime. All right, for 2D optimization, we want to move on to dynamic range. I know most of the sonographers here use dynamic range regularly. But do you really know what it is? Or do you just know if I press this button, sometimes things get better for me? I'd like to try and clear that up for everyone. Let's take a minute to examine these two images. I want you all to decide which image of the fetal brain you are more drawn to, the one on the left or the one on the right, and a couple of reasons why. How about for the rainbows? Which rainbow brings you more joy? What specifically do you like better about one or the other? I'll give you all 15 seconds to take a look at both images, figure out what you like better about the brain and which one you like better about the rainbow. So I'm hoping you are able to pick out some of the differences and one or two reasons why you felt that way. So what is dynamic range and why do we need it? So let's break it down. Dynamic simply means moving. and range is the variation between upper and lower limits of a particular scale. In our case, this is the number of shades of grays that are displayed. We only have two options with dynamic range. We can either increase or decrease it. So, increasing dynamic range means to increase the number of shades of gray displayed for us to differentiate from. As we know, the max number of shades of gray in ultrasound is 256. Thus, decreasing dynamic range means to decrease the number of shades of gray displayed for us to differentiate from. So why and how is this helpful? I want you guys to think of a rainbow, Roy G. Biv. So it has 7 colors: red, orange, yellow, green, blue, indigo, violet. There is in fact a massive spectrum within each of those colors. So let's, for example, select the color red and break it down. Okay. Red contains different shades such as cherry, rose, crimson, ruby, mahogany, scarlet, cranberry, maroon, burgundy, to name a few. It's almost an endless amount just within that color. So let's look at the top left image. We can see as we move from left to right, the shades go from darker to lighter, but it's difficult to see exactly where certain shades end or begin. The image appears smooth or blendy. Now let's look at the image in the middle. We can see fairly well where the different shades end and they begin. Notice there are also less amounts of shades in this image. I would call this image smooth, but not blendy. And finally, let's look at the third image on the right. Not only are the images very distinguishable from each other, but there is a definite contrast between the shades. There is nothing smooth or blendy about this picture. This is exactly how dynamic range works for ultrasound. In an ultrasound image, if we want to make an image more contrasting or less smooth or more crisp, we can change our dynamic range. We're telling the machine, hey, I want to remove the number of shades of gray so that I can easily distinguish the different types in my tissue. Machine, move my dynamic range from 256 to 180. I don't want to work so hard to see the structure. Just like the spectrum of red, we start out with a high dynamic range or high moving scale, showing us all the shades of red. Then, as we move towards the right, we lower the dynamic range. Then we lowered it again. So let's look at an example illustrating dynamic range with respect to ultrasound. Here are 2 video examples comparing the fetal brain, one using high and one using low dynamic range. Let's begin with the clip on the left. The active video demonstrates a dynamic range of 80, while the still image to the right shows a dynamic range of 55. Can you spot any differences with respect to image quality? I would say the clip in general has a more smooth or blended appearance, but I want to see finer detail. Now let's play the video on the right, demonstrating the brain with the dynamic range or number of shades of gray we have to differentiate from, lowered from 80 to 55. What do you notice? Can you see how we are able to see finer detail or a more contrasted or crisper image? This is much like the rainbow when we pulled out and examined the spectrum of red. The lower the dynamic range or number of shades of gray we have to differentiate from, the more clearly we can differentiate the different parts of the structures of the brain. Let's look at that one more time. With a dynamic range of 80, and now lowering dynamic range to 55. Which image would you prefer? Now that we know a little bit more about dynamic range, let's give some structural examples that we would use to lower the dynamic range. We would use this for any structure where you want to see finer detail, something that with a little more contrast or crisper image. So examples of that would be the fetal brain, the fetal heart, nuchal translucency, the fetal spine, and even structures such as adrenal glands. Where dynamic range is less important to be lowered would be for larger structures such as limbs, abdomen, stomach, or placenta. So just showing on our ultrasound machine that this button is very accessible and easy to find. It will take you just seconds to locate it and put it to good use. The second last topic I want to cover is ergonomics. The key points are staying healthy, some frightening statistics, must-knows, and pro tips. According to healthysonographer.com, in an excerpt from Sonographer Safety at Workplace Considerations, 80 to 90% of sonographers will experience pain while scanning at some stage in their career. Just to put that into perspective, at the time of creating this presentation, there were approximately 600 sonographers registered for this conference. That means that between 480 to 540 of you will experience this type of pain sometime in your career. And of that number, this will be career ending for 96 to 108 of you. Think about that. If that isn't powerful or meaningful to you, and if you don't think it could happen to me, these are the numbers, and they aren't good. According to the Canadian Centre for Occupational Health and Safety, there are 3 types of work-related musculoskeletal disorders: muscle injury, tendon injury, and nerve injury. These types of injuries are caused by the following: fixed or constrained body positions, continual repetition of movements, forced concentration on small parts of the body such as the hand or the wrist, pace of work that does not allow for sufficient recovery between movements, and for sonographers, we mostly have pain in our shoulders, neck, or wrists. So what can we do about it? It's so important to scan from the patient and not the machine. So many of us are guilty of setting up the room before going in to get the patient. Then we might move the bed up and down and call it a day. To achieve good ergonomics, it is absolutely crucial to set up your machine after the patient is positioned on the bed for the exam, then and only then. I must admit I'm totally guilty of a pre-set up room based on my exam and not my patient. One way to achieve good ergonomics is by scanning with the magic triangle method, which I will touch base on in the next slide. Knowing how your machine moves and operates is also essential to preventing work-related injury. As we all know, regular stretching and massage also helps. Knowing good resources like thehealthysonographer.com is also beneficial to every sonographer. All right, let's dive into this magic triangle, invented, tested, and approved by healthysonographer.com. Scanning from the patient versus the system. How do we achieve both a sonographer neutral position and a patient engagement position? First, again, we need to start by setting up our work position from the patient perspective and not that of the ultrasound system. You'll be facing the patient and thus in a patient engagement position. How do we scan in the magic triangle? Our body should align similar to driving. You're looking forward, any reaching you're doing is forward to the steering wheel and to the stick shift. So first, we want to rotate our console away from the bed to align the trackball with the elbow and the wrist. And second, we want to float the monitor towards the patient. Video examples of this scanning practice can be found on healthysonographer.com website. So let's talk about machine operations and what is important. I want you all to take out your phone and take a picture of this page. These are the buttons and knobs you will need to become a pro sonographer and to take you to the next level. How to change and adjust the height of your machine, how to move your viewing monitor, how to swivel your console, how to lock and unlock your swivel in place, how to lock and unlock your wheels, how to do a hard shutdown, how to access all of your presets, and how to access all of the calc packages. While we have our phones out, I also want you to take a picture of this slide. This is one of the best resources I have found to date, and that is saying a lot. It is super user-friendly to understand, full of examples and videos, and loaded with information that will help us all prolong our careers and be able to enjoy life pain-free outside of work. These include the magic triangle, good ergonomics, prevention, healthy machine setup based on exam, including video examples, best practices, daily exercises, appropriate equipment, and free educational events. The last thing I want to discuss with you all today is Knobology. Which buttons are the most important and how do I go about finding them on our respective different machines? You guessed it, here is another Kodak moment. So take out your phones and take a picture of this page. These are the buttons and knobs you will need to become a pro sonographer and to take you all to the next level. Qscan, dual screen, including left, right, and up-down layout function, quad view for AFI, twin view, producing simultaneous 2D and color, scale, color gain, TSO or tissue-specific optimization, dynamic range, filter under pulsed wave, threshold under pulsed wave, and the most important and one of my all-time new favorites, color frequency. So now that we know what buttons are important, how do we find out where they are? Here are some ideas. You should invite your application specialist to sponsor a rounds presentation with your group of sonographers. Usually they will bring food, it's usually free, and always you can receive a CME. You can also access a machine user guide. You can have a copy near the ultrasound unit or a digital copy. Third, don't be ashamed to Google. Even the pros use this as a resource. And the last thing is YouTube. These will show you videos specific to your ultrasound machine. The resources are there, you just have to know where to go. It's always a good idea to have a prepared list for your application specialist to maximize your time together. These things on this list aren't everything. Feel free to add anything you want to know and send them this list a week in advance so that they can properly and efficiently answer all of your questions. It is also okay to ask them for a written response. This way you have those handy for when the specific issues come up. Helpful questions include how to optimize your presets, resources to help you navigate your machine, ask to provide a user guide including a hard copy or digital, how to move your machine to optimize your ergonomics, how to troubleshoot your machine, how to use an emergency ID when work lists don't show up, how to fix a patient you have scanned under the wrong name from your machine if possible, usually that's with newer models, how to restart an exam after you have ended it, how to burn images if possible from your machine, and how to prolong the life of your ultrasound machine, including proper care instructions. I want to end my presentation with the Sonographer Challenge because, to quote an unknown author, you will never change your life until you change something you do daily. The secret to your success is found in your daily routine. So, I've challenged you to the following. Visit healthsonographer.com. Apply Qscan to every single case that you do with both 2D and pulsed wave. Normalize using color frequency. Let's not keep this a secret one day longer. And add one objective of your choosing to work on this year. Scan from the patient and not from the machine. And lastly, incorporate the magic triangle into your daily routine. Make it the magic triangle and not the Bermuda Triangle. I also want you all to remember that learning is a treasure that will follow its owner everywhere. And when you learn, teach. And when you get, give. A favorite quote of mine from Maya Angelou. I would like to share my references with you all. Thank you all for your time and attention, and I hope you enjoy the rest of the sessions.
Okay, excellent. Thank you so much, Janie. I wish you had been the one to teach me how to do ultrasound. As self-taught, my teacher was terrible. So I also want to apologize to everybody for our little technical difficulties. It is because Janie crashed the internet, as she has a tendency to do. She will also be answering some of the chat questions as well. But I have a couple here. Can the Qscan be performed in 3D, 4D, or 5D?
You know what? That's a good question. I'm actually not too familiar with the 3D functions as far as Qscan goes. But I mean, as long as you find out where the Qscan is on your machine, it's very easy to find out if that's going to work or not. Again, another great question for your apps team.
Excellent. There's been some specific questions about different machines, and I think some of them have been answered in the chat. And the message is that, the machines are different, the actual, not to say the brand, but yeah, and as well as the individual machines. So you can get all of the vendor-specific information in the manuals, online vendor clubs, or as you said, asking the local app specialist to bring you free food, which I support. So question, should we be training students using the Qscan or auto-optimize? Or should students be trained to work their way through all the different features so they understand how different settings affect the image?
So yeah, myself coming from kind of an old school scanning point of view, we were told kind of that was the no button. We were not allowed to use Qscan. And I do appreciate the fact that I know how my machine works and what buttons do what things. But really, the Qscan has come a long way at this point with our machines, and they're correcting for a lot of that stuff. So yes, it's good to know things and to kind of have a list of how those things work. If you're a Qscan, you don't have it on your machine, or you're until you're unaware where it is. But I think that technology's come a very long way, and to be able to utilize that right off the bat, it's very easy and very efficient.
Excellent. And just sort of as a to shout out to all or to Janie's amazing teaching, but just one of the messages, I don't know if that as simple as it is and goes back to what Karen was saying, even just to start to say the importance of zooming, right, depth and focus. And so working on all these other new ways to make the images perfect. In the meantime, let's just even start with that. So, and we can do it, right? You can make your images better. So at this point, yeah, for sure. So Janie's going to answer some more of the specifics. People are going to need a little break to go walk their dogs, and if you're in Nova Scotia, to shovel your driveway and grab something to eat, and then we'll be starting back at 1:25. And just so that you know, we will have to, given the technical difficulties, to prevent that from happening again. We are Jeff, who, by the way, thank you so much as our audio visual person, sorry, coordinator, manager, production manager, is going to just sort of reboot, for lack of a better word. So you will have to refresh your browser. And otherwise, when you come back at 1:25, otherwise, I will see you then. Okay.